joining us again. We've got a great podcast today planned, talking about inflammatory eye disease. I'm here with Dr. Terrezza, and we have with us today Dr. Corredor. And Dr. Corredor, we appreciate you joining us today. It's always fun. And give us a little background, maybe a little bit, some interesting stuff about yourself.
Sure. Well, first I want to thank you guys for inviting me. It's a great honor being the president of these two guys. I joined the Terrezza group about 5 years ago, actually almost, 5 years and a couple of days. Retired from the Air Force after 20 years. I was a optometric technician for my first 7 years in the military, and then I got out, went to school, and became an optometrist, and finished my career with the military, and then came to join the Terrezza group in beautiful Pensacola.
Well, we're glad you did. We're certainly glad you did. We're going to kind of go in. We'll just kind of open this up and certainly give our thoughts. We all see inflammatory eye disease, and I would say we all see it pretty much on a daily basis as far as things that happen and occur. I know for me, one of the big ones that I see is what we call uveitis. I have some patients that I may see 3 or 4 times a year that have a flare-up of uveitis. What are y'all's experience with it, and what do you think?
Well, I think the incidence is, at least in this area, the incidence varies with demographics, but in this area, I think it's higher than most, and I think it's than most other areas, because the population that we see generally has insurance that some offices don't take. So we get a very concentrated clientele based on that. And our incidence of uveitis, I think, is much higher than the average practice in the United States. That goes for, there's an anterior or front end uveitis, and then there's a posterior, which is the back of the eye. But we see them both.
Well, let's talk, before you, I was just going to say, with uveitis in general, let's just talk about things for the patient to look for. Usually, white part of the eye gets really red. Usually it's painful sometimes, hurts, pain, light sensitivity, things like that that certainly creep up. And it's not just, hey, my eye's red. There's usually more to it than that.
Yeah, for me, I had a little bit more experience, traumatic, because of trauma. I spent, as I mentioned, a few years with the military, and being deployed in Afghanistan and other parts of the world, you see a lot of trauma, and of course that's going to cause inflammation to the eye, and you basically treat it the same way as you treat a normal uveitis, but for me it was more trauma than just the run-of-the-mill kind of uveitis.
I was just going to say, there's some things patients will call, or they'll send me, we've all had family members or friends send pictures, at the weekend, or say, hey, what's this? Yeah. And there's some things will just go away on its own. But uveitis is usually not one of those things.
No.
It starts sometimes mild, and it keeps building from there. It gets, more light sensitive. You can't open up your eye. You can't go outside. And those are things that you definitely need to come in, because, it can get serious. Like you said, it can start anterior, posterior, but if you get a full uveitis throughout the whole eye, it can turn bad really fast.
Well, it's a vision-threatening disease, so you've got to be careful. The analogy I use with the patient is, if you come in when it's a campfire, I can put it out with a garden hose. If you come in later and half the garage is on fire, that's a different program. And if it's more than that, then we're talking specialists, most likely retina specialists and other types of ophthalmologists.
Yeah, and that's because if it's in the anterior, usually a steroid or whatever, what we're prescribing can reach that. The further it gets back in the eye, the harder it is for that topical drop to get there, and then certainly injections or other means have to get in the oral and has to get in there involved.
Absolutely.
So uveitis is a big one. We get the question quite a bit, especially if I have a kid or who has it. The parents want to know what causes it. Sometimes we don't know. Sometimes it's an injury or a trauma or surgery. Sometimes it's an infection.
Yeah, could be an infection.
Sometimes it could be, especially for the patients that I mentioned that I see a few times a year, most of those patients have an underlying autoimmune disease that makes them more predisposed to have it, and certainly it becomes more of a chronic issue in those patients.
Yeah. I think it's important to bring up that when you call any of our offices, that if you have that pain, our staff is trained for triaging. That's a fancy word that means they're able to distinguish between whether your problem is minor or major. Usually with those kind of symptoms, we try to get you in the same day.
Well, I'm going to switch gears because we went to uveitis. Let's talk a little bit just about general keratitis. What do you see? What to look for? What are you telling patients? If a patient comes in, let's say they have a keratitis and they're hurting, how would you treat that patient? Or what would you tell them?
Well, it depends. If it's a recurring keratitis, that's a whole separate game in and of itself. If it's a first-time occurrence, then you have to look into the cause of that. What was the etiology of that? Oh, they were cutting their lawn with their lawnmower and it spit out a foreign body and it hit the front of the eye, and it was 2 days ago, but it's getting much worse as we go. Chances are that's keratitis as one of the possibilities, not the only possibilities. You have a lot of inflammation, redness, light sensitivity, the same things you'd have with a uveitis. By the way, these things are named by their name. Itis means inflammation in Latin. So that is an inflammation of the particular part of the body. Corredor refers to the front of the eye, so it's an inflammation of the front of the eye.
Which is the cornea, the front of the eye. So we're going to talk a little bit about conjunctivitis in a second, which has to do with the white part of the eye around the outside of the iris and that sort of thing. But a keratitis, to me, and a lot like conjunctivitis, patients will call up and I think they assume, especially with the conjunctivitis, they have red eye, which a lot of times they'll say, "Oh, I have pink eye," or is it viral? Is it contagious? And so that's what we're trying to determine when a patient comes in, whether it's a keratitis or a conjunctivitis. Is it a bacterial cause? Do they have an infection?
Yeah.
Is it viral? Do they have something systemic going on? Or do they have a upper respiratory infection or anything like that? Is it fungal? Is it allergies, allergic? So there's a lot of things it could be, and so we need to determine what the cause is. That way we can appropriately treat the patient with the right medication.
Like Dr. Terrezza was saying, a lot of the times, usually, especially in one of our offices, where the demographic is more the working environment, and they work on cars, or they do a lot of manual labor. They come in and they have a piece of something in their eye. Number one, we got to get it out of there, because until you get it out of there, that inflammation is just going to continue to fester and fester and fester. So that's find out what the problem is and start the appropriate treatment.
Well, there's a lot of keratitis I worry about, but I would say in general, especially with contact lens wearers, things like that involved, it can get nasty really bad.
Scary.
I mean, we've all seen, I think, unfortunately, cases where there's been, it's been so bad where an ulcer was bad, where it left a permanent scar in the eye. And so these are things you do not want to play around with. So, if it's hurting you, light sensitive, you're a contact lens wearer, you can't wear your contacts, you've got this going on, it's red, certainly give us a call, come in, because some of these things could leave a permanent scar, but the worst case, it could scar your whole cornea.
Loss of vision.
In some cases, it even leads to blindness and possible loss of the eye.
Yeah, loss of vision. And
that's correct. And we have in stock at our offices tests like the A1 test, and that's a test to determine if you're contagious with an adenovirus, which is a type of virus that's very common, by the way. And we know what it is it runs like a pregnancy test. So if you see a red line in between two blue lines, you know definitively that's what it is, as opposed to a general supposition by the physician's assistant, ER, or optometrist's office. And so it's nice to have that kind of definitive test, which has 98% accuracy.
And we also have, unfortunately, I've associated with hospitals, and a lot of the hospitals don't have a microscope or a slit lamp that we use in office that gives you that high power magnification to actually look at things. When you go to the ER, they may have like the little magnifying, like 5x kind of thing, and they put a little bit of the dye and look in there with this little magnifier. They can't really see anything. But when we come, when you come or call into our offices, we have the power to look at that and go, whoa, look at this thing, look what I found. And again, start the treatment appropriately.
Well, I know for me that there's a lot of things I'm looking at when a patient comes in. Is it just one eye involved? Is it two eyes involved? The questions I usually ask are, how long has it been that way? Is it painful? Are you light sensitive? Is there discharge? Because sometimes the discharge of coming out, if
it
it's
will guide you
green,
in a different direction.
If it's yellow, that can kind of help guide you as well. Do you have an upper respiratory infection? Do you wear contacts? These are questions that we ask the patients, not because we want to ask questions, because that helps us to kind of get to the answer. And if we can get you the right medication and get this thing taken care of, because there are some that the ulcers are really bad, especially these contact lens wearers, that it could be fungal, it could be bacterial. Sometimes we have to treat it both ways to make sure we get it addressed.
Yeah. Some of them are easy because they come in the office, looking down, covering one eye, and you'll automatically, whoa, this patient is in a lot of pain, and we got to get them in, and that's why we got to make sure that we have some room in our schedules to make sure that we can absorb those patients that call in the same day and say, hey, I'm having a severe problem, an acute problem, and we can get them in there and get them treated.
And not only treat you, but most of these extreme cases we're talking about, we're going to be following you very very frequently.
Oh, absolutely.
If not every day, maybe every couple days follow-up to make sure with the medication that it is getting better. Because if it's not getting better, we need to do something different. Yeah. We may even have to culture the ulcer or the cornea to figure out exactly what the bacteria or whatever the bug is that's causing it to begin with.
Mm-hmm. And it's very important to note that some of these patients that come in are not our patients. But we see you with those kind of symptoms regardless of whether you're a patient of ours or not.
And that's, certainly there's, we ask a lot of questions. I know sometimes patients will say, why do they need to know this or why do they need to know that? But we always ask about allergies, we ask about systemic conditions, because when it comes even to things like this, we want to make sure you're not allergic to a certain antibiotic or a certain medication that we would quite often sometimes maybe prescribe for you. But if you're allergic to that, there's usually an alternative that we can kind of go with or sub out if you've had a bad reaction to something in the past. The next topic, kind of going through keratitis, conjunctivitis, thyroid eye disease. To me, that's the one I turn on the television. I hear a lot about nowadays is thyroid eye disease. So I'm glad it's talked about. I'm glad patients are becoming more aware. They need to come in and get that looked at with their eye care provider. But what would you say? Yeah, thyroid.
Well, thyroid disease in general is one of the most misdiagnosed systemic conditions in medicine. So therefore, a lot of patients have it but don't know they have it. And usually it has to hit a point where they'll get some irritation in the eye before they'll come in and we suspect that it's thyroid eye disease. It mimics other diseases too. Dry eye disease can do it. An allergic reaction can mimic some of the symptoms. But generally, in the more extreme cases, but even in the moderate cases, it will bulge the eye out such that the eye doesn't close correctly. And when it does that, the front of it tends to dry out because it has tears on the front. And at those dried out spots, they can develop a keratitis. But the keratitis will not necessarily produce a pain symptom. They'll just get used to it so much that they'll put up with it even though it's bothering them, which is not a good state of affairs either.
And those are the patients will usually look at the cornea and say, man, all that keratitis or SBK, and then they wonder why they can't feel it because they're just kind of, their sensitivity has gone down because of that. But, you mentioned enlarging of the orbit, proptosis, which would be pushing forward of the eye from, things in the orbit, fat is pushing it forward. Certainly those are things that we measure with a Hertel exothermometer to make sure, are they symmetrical? Is it going forward more than the average? Mm-hmm. Those are things that we want to know because, it can get extreme sometimes. Sometimes it's just as simple as, hey, it is dry eyes. But other times, these patients, they have to do like an orbital decompression, get them referred out to do something because, bulging forward of the eye, especially in a large amount, is not good.
Yeah. And again, we want to make sure that their primary care provider is aware that they're having this condition so that they can manage the treatment, because it's not really the eye causing the problem, it's the underlying condition with the thyroid problem. And of course, if it's an autoimmune disease, which is what causes the inflammation of the muscles and the fat deposition, all that stuff, there's actually some treatments out there now that we have available that can actually reverse those effects and make the patient look and feel a whole lot better, on top of lubrication and helping the patient to do some good blinking and spread those tears throughout the eye.
Yeah, that was a revolutionary drug. The name of that was Terrezza, not Terrezza. Terrezza.
Get them mixed up there.
Yes.
Well, whatever you have, Graves' disease, hyperthyroid, hypothyroid, your T levels up or down, come in. Let's get the annual exam done at least. And then certainly, if there's, even if it's not you already had your annual exam and you're having pain, you're having this or that, and you have thyroid issues, come in. We want to look at that. We want to address it. We want to, get you feeling better off the bat, but we also want to make sure it doesn't lead to anything serious down the road. We've got a couple of questions here. Let's try to see if we can get to at least one of these. Question one is when because the kids are going back to school, we started back here, pink eye is something that typically gets spread easily among younger kids. What preventative measures can I take to minimize my child risk if a classmate gets it? Wow.
Well, I mean, obviously, good hand hygiene, wash your hands, either soap and water, or hand sanitizer, because unfortunately we all touch many things, handrails, the pencils, kids are just, my wife calls them a petri dish, because that's where they are. They just accumulate stuff and make it grow. And we want to make sure that if they do come in contact with something, that they get rid of it. That's first line of defense, Clean your hands, don't touch your eyes.
Well, I like it when they come in my office at least, or our offices, that we run that A1 test I referred to previously, because many kids miss a week of school unnecessarily. Once you get a negative on that A1 test and you begin treatment, you can get back to school hopefully the next day, and you miss missing a week of school when it was unnecessary. So it's very important to have that test, in my opinion.
I think that's a very, very good point. Is a lot of times we kind of jump to, hey, my kid has a red eye or the white part's red, and we automatically assume, that it is pink eye, meaning it's viral and contagious. And sometimes it may be, but oftentimes it may be something that's not. It's not going to be contagious. The kid doesn't need to miss school. The other kids don't need to be worried about it. So we want to get that answer as quickly as we can, get them back in school, and make sure it's something that everybody can feel comfortable with. We appreciate y'all joining us. Appreciate Dr. Corredor joining us again for this segment. Until next time, certainly like us, comment on our Facebook, join it. Go to our website, TerrezzaOptical.com, if you want to check out any of our locations. We've got staff that can help with any questions you have, help with insurance to kind of figure out things. We'd love to help you. We'd love to see you. All offices are seeing new patients, so feel free to give us a call. Thank you for your time.
Thanks for having me, guys.
Appreciate it.
Appreciate it.